बोले।
Hello, good afternoon. Welcome, doctors, to this webinar on Carbetocin in action by Heathrow. Heathrow Healthcare, as you know, we have got 25 years of excellence. We have got 300 plus products in our portfolio, 36 state-of-art manufacturing facilities, and 21,000 employees globally. We are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have got presence in 126 plus countries, and we have got Asia's largest manufacturing facility as Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360 degrees solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India. We have a wide product range encompassing multiple specialties, pioneering in quality and innovation. We have distinction of bringing 4 biosimilar products to market within 5 years of introduction. Today's webinar is on Carbetocin in action. You all know that carbetocin is the drug which is used for prophylactic management of PPH, postpartum hemorrhage. And PPH is a condition, you'll all agree with me, is better to be seen, better to be read, better to be discussed than actually seeing the patient on PPH. Of course, we can expect the unexpected, any patient can go into PPH, but it's a condition with potential disaster. Although there are a lot of studies and many studies and publication of carbetocin in PPH, we always like to have our own doctor's experience in use of carbetocin in PPH. Today for that, we have got Dr. Binal Shah with us. Welcome, madam, to this webinar.
Yeah, thank you so much, and a very good afternoon to all of you.
Dr. Binal Shah is consultant gynecologist and laparoscopic surgeon. Madam is MT obstetric gynecology gold medalist from MS University, diploma gynec endoscopy in Germany, CIMP FICOG certified in aesthetic gynecology. Madam is attached to Dwarkesh Hospital, Vadodara, Gujarat, Foxy representative from BOGS, National Chairperson IMS Public Awareness Committee 2022-24, received Best Committee Award, past President BOGS 16-17, past President Menopause Society Vadodara 21-22, Consultant PCOS Club India. Madam has received Best Paper Award at ISG Conference Aurangabad 2011. Best Video Presentation at ISG Conference Ahmedabad. Awarded Inspiring Gynecologist of West India by Economic Times. Awarded as Wonder Woman of Vadodara by Radio City 91.5 FM. Appreciated by CM Sri Rupani ji for women.
Thank you, Dr. Prashant.
Most important, madam, it's been I'm Pride of Baroda Healthcare Icon Award by Times of India. The interest is laparoscopy, aesthetic gynecology. Welcome, madam, to this webinar, and over to you for further.
Yeah, sure. Yeah. Thank you so much, Dr. Prashant, for the kind words. And yes, dear friends and colleagues who have joined in today. Today, this afternoon, we are talking about something which is the nightmare of any obstetrician, that is the postpartum hemorrhage. And all of you would agree to me that this is a dire consequence, and unfortunately, India ranks like 25% of global deaths in postpartum hemorrhage belong to India, and it is a major contributor of maternal mortality. Almost 40% of the maternal mortality is contributed from postpartum hemorrhage. And often, when we talk about the inquiries into confidential inquiries into deaths, often the problem which is found out is that too little was done and too late. So yes, can we have the next slide, please, Dr. Prashant? So traditionally, it is defined as a blood loss of more than 500 ml. Next. But next slide, yeah. But we know that, it is not exactly the quantification of the blood, but how much it, hampers or makes changes in the vitals of the patient. I mean, how well she can tolerate that blood loss. That is most important. And as we just said, that it is the leading cause of maternal mortality in India and all over. Next, please. And as we all know, the 4 T's of the postpartum hemorrhage, that is the tone, thrombin, trauma, and tissue. So being obstetrician and gynecologist, definitely we are aware and we should be vigilant enough to rule out any trauma to the genital organs and immediately repair them. Obviously, we have to rule out retained placenta or any abnormal tissues in the vagina. But the most important and the most common cause, as we all know, is the uterine atony. As we are aware that the uterine myotamponade, the strong contraction and retraction of the muscles of the uterus, is the main reason of stopping of the blood from the placental lakes. And whenever it fails to happen so, there is uterine atony, and that can lead to torrential hemorrhage. I mean, a female can, in matter of minutes, she can be drained of her entire blood volume. So tone is the major component of postpartum hemorrhage, and that is what we have to tackle. Thrombin, coagulopathies is a rare scenario, but we definitely need to keep in mind. Yeah, next slide, please. And as we are aware that clinical findings, all these findings are enumerated, but I would say that you have to pay your attention first to the maternal tachycardia. So whenever there is a tachycardia and a hypotension, you have to be alert, and that red flag has to, start blinking in your eyes, that now is the time when you need to be very much alert. Next slide, please. So coming to the diagnosis, as I said, that you have to assess the patient's status first, and a patient who is a borderline anemic, like, frankly speaking, we have to raise our thresholds. All of you will agree that, whenever we see a hemoglobin report of 10 grams, so we are like, okay, chalta hai karke. But we are all aware that the normal level is like more than 12. Like Foxy had given this mantra of more than 12. So we have to increase our threshold and prepare our females for, I can say birth preparedness or labor preparedness, where we have to build up optimally the females before labor to at least a hemoglobin of 12. Because what happens is that when she is at a hemoglobin of 9, 10, then she is not able to tolerate even the normal blood loss, and that leads to all these signs of shock which we can see. Next slide, please. And here, one more thing I would like to emphasize is that it is not, the things which we do one by one. Everything, like the care pathway which was given by Foxy, that it's a team approach, and everybody in the team is supposed to know what they are supposed to do. Like, IV line, obviously, it is assumed that in a hospital delivery, it's always there. But you might require a white bore needle, you might require the blood sample collection, the laboratory investigations, but you cannot wait for them to come. Before you get the reports, depending on her signs, symptoms, you have to start the treatment, the blood transfusion, the coagulation products. And even much before that, I would say that let's not allow her to bleed that much, because it is purely in our hands to, control that hemorrhage. The next slide, please. And especially we have so many products for atony. Now, whenever I'm discussing about the ecbolics or the uterotonics, the first and foremost thing which comes to our mind is like the gold standard, that is the oxytocin, right? So when the oxytocin was there, what was the need of, developing a new molecule, or what was the need of getting certain updations done in oxytocin? The problems with oxytocin which were actually not frankly realized, and we used to really wonder that sometimes, especially like I belong to Gujarat state, and there it is very common to have temperatures of around 40-45 degrees centigrade in summers. And when we are not very vigilant or alert about our stock, often the oxytocin is lying at room temperature. So you can imagine that at 40-45 degrees centigrade, it is not going to be effective. So you might give her 20 units, 30 units, but somehow you are not satisfied with the tone of the uterus. And that's when we realize that probably there has been some problem with the cold chain problem or storage problem. And because of that heat, the oxytocin is not stable enough, and it is not giving us the desired formulation. So that is how more heat stable oxytocin, that is the carbetocin. So carbetocin is a synthetic analog of oxytocin, and it has the affinity for the myometrial oxytocin receptors, and it provides us the uterine tonicity, uterotonic activity which we are looking for. And the advantage, the two major things which it has is, one is the heat stability, especially in country like ours, and second is the extended half-life post the IV injections. And so it doesn't need a cold chain storage or the logistics. As you can understand that when we are working at grassroots levels, in peripheries, in rural areas, and dear friends, you will all agree that the major chunk of the PPH deaths, it is coming from the rural population, the rural area where there are problems of, transporting the patient, the cold chain is not maintained. Often, expert doctors may not be available. So there are a lot of, it is a multifactorial thing. We cannot just pinpoint to one thing, but then, stability of oxytocin is something like a major contributor. When we are relying upon that drug to, to have the tone of the uterus, and if it fails, you can imagine the plight of the obstetrician. So again, I would like to highlight, carbetocin is heat stable. It has a shelf life of 24 months at 30 degrees centigrade, and it doesn't need any cold storage or logistics in the transport. It is provided in form of a vial. 100 microgram in a 1 ml vial. Now, all of you are aware, like when the utrotonic has to be given. Next slide, please. And these are the timing of administration, and we are not going to wait for the postpartum hemorrhage or atony to happen. It has to be used prophylactically only for the prevention of postpartum hemorrhage. And all of you would agree that nowadays, the days are gone when we used to say that the third stage is a stage of inactivity, right? This is a stage where we have to be the most vigilant and proactive and actively manage the third stage of labor, right? And the options which we have in our hand are the oxytocin, the carbetocin, ergometrin. Frankly speaking, I've just forgotten when I had used it last. In my residency days, yes, we were using it. But nowadays, more than 25 years into practice, and especially after the advent of carbetocin, even the use of this thing has also reduced like anything. Carboprost has reduced like anything, which we were previously using, especially in patients of PIH and all. And another thing which we are commonly nowadays using is the misoprostol. Misoprostol again has an advantage of being in a tablet form, so no IV or IM injection is required. So even a unqualified or a slightly qualified person like a birth assistant or a DAI can also use it per rectally. So no special training would be required. There was even one discussion where they were thinking of prophylactically giving the female a misoprost that as soon as she delivers, she's herself supposed to administer. But anyways, let's see what happens to that. Coming to the next slide, please. So yes, again to reiterate that carbetocin is the next generation drug for PPH management, and it is a long-acting analog of oxytocin, and it is therapeutically indicated for prevention of postpartum hemorrhage due to atony. And 100 microgram in 1 ml of vial is available. And next slide, please. The mechanism of action, as we are aware, is that it binds to the receptors, and that is how it triggers the generation of the second messengers and the diacylglycerol. And binding of calcium to calmodulin stimulates the uterine smooth muscle contractions. Next slide, please. So normally we are giving this IV slowly. And clinical evidences, there have been many studies. First and foremost, next slide, is the champion trial by the WHO, where it was a international randomized double-blind controlled trial, and it proved the non-inferiority of carbetocin over oxytocin. Next slide, please. And it was found comparable. The blood loss, and the need of other utrotonics, everything, there was no significant difference between the two groups. So it was concluded that carbetocin is non-inferior to oxytocin. And in practical, next slide, please. And this was the Cochrane review summarized and supported the use of carbetocin. Next slide. So we have some guidelines as well and recommendations, where now we can see that carbetocin has found its place in all the guidelines, that is the WHO or the FIGO or the FCOG guidelines. Everywhere carbetocin has proven its role. Next slide, please. Yeah, so I would like to share my own experience with carbetocin. I am a regular prescriber of carbetocin from the day it was launched, as being very much convinced about the superiority, ease of administration. And what I feel as a major advantage is that there is no need to give a infusion. Already the patient, like sometimes, for example, certain patients like anemia and all, we don't want to overload them with fluids. And giving them a lot of fluids and giving in an infusion form, often here, just the IV bolus dose given slowly, gives you an effect which is very fast, very reliable, and sure. So nowadays, everywhere I have replaced, like misoprostol is always used, but apart from that, carbeprost, I don't remember using it. Methergin, I don't remember using for ages. So it is being used prophylactically in all my cesarean sections, because cesarean, as you know, is a high risk situation where the possibility of PPH is more. Besides that, we are also getting, all high risk patients like PIH or twins or obesity. So again here, and many patients are on aspirin or low molecular weight heparins throughout the pregnancy because of bad obstetric history. So in all such scenarios, use of carbetocin makes us more confident in tackling PPH, and I'm personally very happy with the use of Carbetocin. I'm also using it in normal vaginal deliveries also, and mainly the main advantage I see is that it negates the requirement of giving multiple infusions for the prolonged time. And I mean, actually, the need of other extra uterotonic has reduced. Even the need of blood transfusion has also significantly reduced, and the patient hemoglobin status is also maintained quite well. So that is my personal experience. Plus, I have not, seen any patients like of urinary retention or tachycardia or hypertension, which used to happen with certain ecbolics or diarrhea. Like, for example, with carbiprost, we used to always, prophylactically give Rydol because many patients used to have a diarrhea. Or even like, for example, carbiprost is also contraindicated in patients with asthma. So in those patients, we can, safely give this. And in some patients, we see anuria or a renal shutdown when we give prolonged such or ecbolics. So here with Carbetocin, my experience has been quite good. Yeah, so I think Dr. Prashant, that's what I had to share.
Yes, wonderful, madam.
Yeah, thank you.
Yes.
So we can open the floor to
Yes.
discussion and input from the other participants.
Now, it's very interesting that you have I think you must be using it in almost all questions, in all patients.
Almost, you can say, yeah, almost. I mean, yeah, 90%.
And Argot, of course, is no more used. But in my college days, Argot, we had only Argot and oxytocin once upon a time.
Exactly,
Yes.
yeah.
And you have already mentioned your experience of using Carbetocin.
Yeah.
So we'll go to the next question.
Yeah.
Which patient profile can doctors anticipate a PPH?
Yeah, so that I already mentioned that, certain patients we can anticipate and are high risk at a developing of postpartum hemorrhage wherever there is undue distension of abdomen. So it can be like, twins, multiple pregnancies or polyhydramnios. Then wherever there is precipitate labor. So, excessive uterine activity and then sudden delivery, like that is the precipitate labor. Then grand multiparas, where the uterus has the chances of atony, just like what happened with Mumtaz Mahal, right? So those scenarios where the PPH possibility is more than other scenarios where obviously even PIH is a very, very major contributor, that is the pregnancy induced hypertension, and we have a big chunk of patients having PIH. Then there are certain patients who actually are not able to tolerate even a normal blood loss well. That is the anemic patients. Yeah. So the blood loss, if you quantify, may not be more. But, the tolerability of the patient, because she's already anemic. And so, and those patients, the chances are more. And here I would like to, add one line, which is, I would say that last but not the least, that you have to anticipate PPH in each and every case.
Absolutely.
Because actually, where you actually falter is that when you take the things too lightly, obstetrics is, it can cheat you, and suddenly you can see unexpected, unpredictable hemorrhage in even a normal case scenario. Totally a normal case, normal vaginal delivery, a primey, everything going normal, and suddenly you're taken with a surprise.
You always expect the unexpected in every patient. Yes. Surprises are always there.
Yeah.
Right. Yeah. So patients where you anticipate PPH is always better to be proactive and take.
So you have to be on your, frankly, being an obstetrician, you have to be on your guard all the
time. Absolutely.
But yeah, definitely there are some patients whom you would like to segregate and kind of, keep a extra watch. Especially you will also put a word to your staff that in this patient you have to be extra careful.
When would you actually prefer a Carbetocin or oxytocin for prevention of PPH?
So frankly speaking, after the introduction of Carbetocin, I'm using it in almost each and every case. Yes, as a first line rather than, so mainly oxytocin I'm using only for augmentation of the delivery. Yes. Induction, again, I'm using more of Serviprime gel but for augmentation, I'm using oxytocin, and postpartum, I'm using Carbetocin. Yeah.
Can we use Carbetocin in case of retained placenta? Any experience here?
Yeah, so basically it is the same thing. It's going to do the same work as oxytocin. The
Oxytocin
main
does.
advantage will be that you don't need to give a very high dose infusion
Correct.
for a prolonged time.
That's right.
So, and if it is a detached bit of placenta which is just lying there in the cavity, or slightly loosely adherent, then probably a powerful contraction can detach it.
Expel it.
But yes, but if there are some other reasons for it being retained, then probably we'll have to change the modality.
On the manual variable vocal, etc. may be needed.
Yeah.
Can we use carbetocin in Rh negative mothers? Here, a PPH could be a major disaster. Patient may not get blood, etc. Can we use it in
Yeah, definitely. I mean, there is nothing to hold us back
contraindication?
from the yes.
If a doctor uses can a doctor use carbetocin for prevention? I mean, we have answered on this already.
Yeah. So here, just one line I would like to add in the question number 6. That yes, definitely when we are using oxytocin for labor induction, we can still use carbetocin. But here, one thing which I would like to alert is that if it has been a very prolonged labor induction, and especially in the cases where we have given a trial of vaginal and finally we could not succeed, and then we take the patient for cesarean. In those situations, I have found the carbetocin to work a little suboptimally. Probably, I feel that when you give oxytocin for a very prolonged period of time,
The receptors
very
are
long,
blocked.
then all the receptors of the oxytocin gets blocked, and now
Correct.
carbetocin is going to work from the same receptors.
Correct.
So
That's
here,
possible.
yes. So here you should take help of other uterotonic agents, especially because if finally, it results in a vaginal delivery, then, you can understand that the contractions were well enough and even the carbetocin is going to work. But when we had to finally take the patient for cesarean in spite of a prolonged trial, probably here, you will have to keep a backup besides carbetocin, something like a misoprostol, or if required, carboprost or something, some other molecule, because all the oxytocin receptors are already blocked.
Something acting by some other mechanism rather than same oxytocin receptor.
Yes.
Do you prefer IV route or IM route? Generally.
So generally IV.
IV route. But any specific place for IM? Or I think IV is the...
I feel that is the route of choice. I mean, and we assume that it is all the patients who are in labor have a IV line, and that is a better way to have a more predictable response of the drug.
And what is your take on the pre-filled syringe of carbetocin?
I mean, that actually will help and aid the
speed,
ease of
yes,
administration.
the
speed. And because there are a lot of things to manage at the time of birth of a baby. I mean, the obstetrician is fully engrossed in obviously the birth of the baby. The staff is helping to hold the baby in the tray. Probably a pediatrician is there to resuscitate the baby. And then suddenly, there is some assistant or an anesthetist or somebody who has to give the drug. So if it is a pre-filled thing, then probably he will not require anybody else's help to fill the syringe or something.
And sometimes, picking up the solution from the needle, I mean, we may miss something, we may drop something. I mean, it always happens that the full dose may not
I mean, you are sure that, the adequate dose is going the perfect dose.
Exactly.
Yeah.
If a patient is not responding with carbetocin, I mean, you have already answered this. You would use all other drugs, other.
Yeah.
What are the advantages of carbetocin? Especially, I want to know, with oxytocin is known to give ADH side effects. How common is this ADH side effects?
So it's not very common, but I mean, certain patients are more prone to it. But again, especially it happens when you give prolonged infusions and a high dose infusion oxytocin for a prolonged period of time. In those patients, we have seen the anuria and ADH.
An advantage
or meso, basically, I mean, it causes lot of hyperthermia and tachycardia and vomiting and all those things. So orally, normally I don't use it. Majority in patients of induction and augmentation, I use it vaginally, and that also just 25 milligram. And postpartum, I use 600 milligram per rectal.
Carboprost advantage?
Carboprost, again, I mean...
Asthmatics, of course, the first thing.
So here we'll not be able to give in asthmatic patients. Then it used to cause diarrhea in a lot of patients. So
and
normally...
It's quite possible, I suppose, that we may not know the history of patient, whether the patient is asthmatic or not. It can't happen. It may not be in the cities, but in the remote interiors. Yeah,
so bronchospasm or something might be triggered because of the carbetocin.
And
for the carboprost.
Carboprost,
Yeah.
Methyl ergometrin, of course, hypertension.
Hypertension. So already a patient of PIH or something, and then suddenly the blood pressure may shoot up more. Yeah.
I mean, you're already using it as first line. This
Yeah,
question.
I'm using it as a first line, so I have not kept it for reserve.
When you have the best, why keep it for reserve and wait for
Exactly.
situation?
Give your best to your patients.
Exactly. How would you compare, especially adverse effects of carbetocin and oxytocin? Any embolus, any ADH effect, anything? You have used carbetocin extensively in the past 2 years or so.
Yeah.
Any side effect you have seen of carbetocin?
As of now, no, except I already told you that in certain patients,
Yeah.
it not give that much effect as
yes.
what we are expecting, as already discussed.
Oxytocin being used.
And mainly, here, I mean, oxytocin, as I said, that we have to give prolonged IV infusions. So in certain patients, we don't want to give them a lot of volume overload.
Correct.
So in those patients, this has much more advantage.
And then you have to give furosemide and other things. I mean,
Yeah. Your
one line on all this carbetocin, take home message to the audience.
Yeah. So basically, I feel that carbetocin is miracle molecule. It's like a breakthrough in the field of labor management because it gives us all the advantage of being heat stable, providing a sure, short, predictable outcome of a uterine tonicity. And we are not worried about how it was preserved or how was the cold storage and chain of transport and all those things. And plus it is well tolerated, so we are sure of patient comfort as well as good effect. So I feel should be used as a first line management in labor management for prevention of postpartum hemorrhage.
Well, madam, thank you so much for your inputs. These practical inputs, I'm sure, will help the doctors who have attended this. It is these inputs which are necessary to them rather than reading textbooks and references. Our own doctor's experience.
And so I feel that, it is like not only evidence-based guidelines, but,
practical
experience-based guidelines.
Exactly. And most important is, that cold chain not requiring, which is, I mean, in Mumbai itself, there is a lot of power outage. I can imagine what would happen in the interiors.
Right.
But plus, you may not get help, for IV, etc. I mean, practically speaking, carbetocin would help in those situations.
Yeah.
Well, thank you so much. I'm sure the doctors must have benefited. Thanks all the doctors who have taken time to attend this webinar. Thank you, marketing team, Pritam and your team for this conceptualizing. Thanks, field personnel of Hetero for super coordination. Last but not the least, thank you, Jayant and your IT team for super backup support. Thanks all of you. Signing off. Thanks, madam. I wish you a very pleasant afternoon.
Yeah.
And all the best once again for the exam.
Yeah, sure. Thank you so much. Thank you.
Thank you so much, Dr. Binan. She left, I guess.
She left.